Hello, I'm Dr. Lisa Bagnall. My colleagues, Dr. Oliver Grundman, Dr. Sanju Yoon, Ms. Marilyn Teolis, and myself completed one of the first formal systematic reviews of the biomarkers and mechanisms related to cancer-induced cardiac cachexia in its natural state. That means before any intervention such as chemotherapy. Cancer cachexia is a multifactorial syndrome that affects up to 80% of patients with advanced cancer. It causes multi-organ alterations and damage, and that includes the loss of skeletal and cardiac muscle mass as well as breakdown. It is also associated with increased oxygen consumption coupled with increased energy expenditure. Cancer progression causes cardiac wasting associated cardiomyopathy, and this is evidenced by the thinning of ventricular walls, cardiac remodeling, local tissue hypoxia, as well as dysrhythmias. The differences between sarcopenia and cachexia need to be covered basically because there remains a lot of confusion between providers over these two processes. Cachexia is an irreversible process. It is a complex metabolic syndrome always associated with pathology, and it is characterized by the loss of muscle and actual muscle breakdown with or without the loss of fat. Criteria includes weight loss of 5% or more in 12 months or less. It also includes 3 or more of the following criteria: anorexia, fatigue, decreased muscle strength, and abnormal biochemistry. Sarcopenia, on the other hand, is loss of muscle mass and strength. Primary sarcopenia is loss of muscle mass and strength due to aging, and secondary sarcopenia is loss of muscle mass and strength due to something other than aging. And it can include things like reduced activity or immobility, chronic disease, and poor nutrition. For elderly patients, 1 day of immobility or remaining in bed can equal 3 days of rehabilitation to regain the function lost in one single day. For further differentiation and explanation, please review the differences between sarcopenia and cachexia video. It's about a 4-minute, 5-minute video on my YouTube channel. Our systematic review, search, and selection criteria included human and non-human models. We looked at the biomarkers and contributing factors for the development and progression of cardiac cachexia over a 10-year period between 2011 and 2021. Our studies were limited to those in English, and these are the databases that we searched. Our systematic review selection criteria included randomized controlled trials, retrospective, prospective, descriptive, cadaver, and animal studies. We used the PICO Porter platform to deposit and review our articles. 2 reviewers initially screened all articles, and then a 3rd reviewer came behind and tagged those that were meeting criteria or to verify criteria. A total of 15 animal and 4 human studies met eligibility criteria and were included in this review. PICO Portal generated this Prisma diagram. It shows how many articles were retrieved, how many were duplicates, what we included, what was not retrieved. Reports and reviews, of course, were not included. We wanted the raw, original studies. Our animal studies focused on the biomarkers and cardiac effects. When we looked at some of the review articles and actually looked for systematic reviews, we saw that they elaborately described cellular pathways affected by the up or down regulation of various biomarkers related to tumor progression, but no one looked at how many times certain biomarkers were upregulated or downregulated over a specified time period. We wanted to know if there was a pattern of biomarker expression between studies. Most of the animal studies focused on GI cancer. There was one on Lewis lung cancer. Mapping was done to look at similarities or locate patterns between the animal studies. In a separate manuscript, Dr. Tana Talavera and myself actually did a mini conceptual analysis to define the mapping technique that we developed in order to look at systematic reviews and also process improvement projects. We use this mapping technique in this particular systematic review to locate any type or identify any patterns between the studies, especially since most of them were related to one particular type of cancer, and that was GI cancer. We developed the acronym Marker Analysis Process Procedure for identifying noted groupings to basically show pattern identification. We separated the factors and counted the number of times these were repeated. The mapping technique used for this systematic review was an inductive process in that categories were added as we reviewed the studies and found different factors, effects on the myocardium, and additional key points. The results showed that there were 4 biomarkers specifically upregulated in close to a third of the studies. That included tumor necrosis factor alpha and interleukin 6, which were inflammatory cytokines, and adrenaline, which is MAFBX, and MURF1, which are E3 ligases. What's interesting to note is that tumor necrosis factor alpha and interleukin 6 are potent activators of E3 ligases, and they're associated with cardiac remodeling. After reviewing these studies multiple times, which was time consuming, we did a further mapping of the 5 studies to look for additional commonalities. Things like number of mice, when animals were sacrificed, injection site, and so forth was looked at to see if we could find a pattern. Ultimately, we found 2 main processes in cardiac and skeletal cachexia. One is the ubiquitin proteasome system, and that is a major intracellular non-lysosomal protein degradation system that eliminates old, misfolded, and damaged proteins. Proteasomes are protein complexes that degrade these damaged proteins through proteolysis, which of course is a chemical reaction that breaks down peptide bonds. We also looked at autophagy that degrades long-lived insoluble protein aggregates and whole organelles, basically phagocytosis. So these 2 processes were the main ones that were cited within the animal studies most frequently. So which process drives cancer-induced cardiac cachexia, and which one is predominant in skeletal muscle cachexia? The upregulation of the UPS or autophagy. So we talked about what the UPS system was, that it breaks down as non-lysosomal protein degradation system. But the actual process starts with E1, which is the activating enzyme. So E1 begins the process of the UPS, and then E2 is a conjugating enzyme, which carries the damaged protein from E1 to E3. E3 actually picks up the protein, and you can probably clearly see that this is a cascading system. E3 then carries the protein to the proteasome for further breakdown. This happens as a cascading system, and ATP is one of those things that is given off initially. So if this protein system or the UPS is accelerated, energy expenditure occurs and is increased. The E3 ligases that were most commonly referred to in the studies was MAFBX, adrenaline, and MURF1. MAFBX attaches to ubiquitin molecules and acts as a tag for degradation, whereas MUF1 upregulation leads to atrophy and downregulation to hypertrophy. Tumor necrosis alpha and interleukin 6 stimulate the UPS pathway of myofiber degradation. Autophagy, on the other hand, is through phagocytosis, or the engulfing of larger proteins or organelles. In tumor cells, BNIP3 responds to hypoxia and regulates mitophagy. And it is, when it's upregulated, it is a marker of autophagy or evidence of autophagy. In the heart, when it's upregulated, it's also associated with decreased myocardial function. BNIP3 upregulated, it forms autophagic vesicles which attach to proteins tagged to be broken down by cathepsins. So cathepsins break down actin-myosin complexes, which in turn allows the UPS pathway to further break down myosin. So sometimes the autophagy and upregulation of UPS work together. Through mapping, our systematic review showed that at the 15 animal studies that were found between that 10-year period of 2011 and 2021, adrenaline and MURF1 were upregulated in 5 studies. Zhu and others looked at in vitro cardiomyocytes and biomarkers of muscle proteins and found the following. They found that adrenaline and BNIP3 and messenger RNA were upregulated in the tumor group. Echocardiogram showed that the left ventricular systolic diameter and percent fractional shortening was reduced. Cardiomyocyte peak contraction and relaxation times were increased. Systolic failure was associated with increased peak shortening or contraction, and diastolic failure was associated with increased time to 90% relaxation. This is normally an early finding, as heart failure is not indicated via echocardiogram in this particular study. So this actually happens before heart failure is noted on the echocardiogram. The posterior wall of the myocardium was also reduced. There were no differences noted in overall cardiac function, such as the diastolic diameters in the cancer group, heart rate, and so forth in the control groups. This probably would have changed during cachexia progression, and that's what the authors cited or assumed. Earlier studies showed severely cachectic mice and rats showed reduced heart rates and systolic dysfunction. One of the most profound studies was Cosper and Lineman's study of mice with pancreatic cancer cells. Some were injected in the subcutaneous space and one group in the peritoneum. What they showed is that male mice had larger tumors, and they found that estrogen may be cardioprotective because female mice had smaller tumors and cancer progression was slower than that seen in male mice. In addition, when female mice were injected with an estrogen antagonist, they lost as much heart muscle as male mice. There was reduced gene expression of adrenaline and MURF1 in the heart compared to skeletal muscles in the tumor groups. So the expression of these E3 ligases were much, much higher in skeletal muscles, and that was evidence of upregulation for UPS. MURF1 adrenaline transcripts were higher in the hearts of mice with cancer cachexia, but again, not as high as what was seen in skeletal muscles. What was interesting is that the ubiquitin conjugation activity, or E2, did not increase in the hearts. So therefore, without an increase in E2, that was evidence that the ubiquitin proteasome system was not upregulated and was not the primary driver of cardiac cachexia. Cardiac muscle loss was a result of reduction of cardiomyocyte size and all sarcomeric proteins. Cathepsin and LC3 was upregulated, and this showed increased lysosomal activation. Both were upregulated, however, LC3-2 was significantly higher in male hearts. Electron microscopy showed evidence of autophagy, or the presence of autophagic vacuoles containing portions of cytoplasm, mitochondria, and myelin or muscle-like structures. So basically, their study showed that autophagy was the main driver of cancer-induced cardiac cachexia. They also showed that the upregulation of UPS was more profound in skeletal muscles, and then that was actually the driver of skeletal cachexia. In Tian's study, 2011, they used a two-group comparison of 5-week-old mice. They injected C26, which is colon cancer cells, into the flank region and sacrificed these mice on day 17. The hearts of the adenocarcinoma-bearing mice had upregulation of messenger RNA expression of MURF1 and adrigan-1. This consistently correlated with high levels of protein ubiquitination or activation of UPS. So they're saying that UPS was mostly the driver of cancer-induced cardiac cachexia. They also noted that adrigan, proto-oncogene, CFOS, and messenger RNA, BNP, and interleukin-6 were also upregulated. They noted the downregulated and upregulated biomarkers in this chart here and the effects from those. But basically, they showed evidence of remodeling and upregulation of UPS. Cardiac remodeling, fibrosis, decreased fractional shortening, which impairs contractile force of the heart, a decrease in intraventricular septum wall and posterior wall thickness also led to cardiac wall atrophy. McAllis and others' 2017 study used pancreatic cancer cells, basically because this was shown because 80% of those with pancreatic cancer develop cachexia. Male and female mice were 7 to 12 weeks old, and there was at least 4 per group. Mice were either injected subcutaneously, intraperitoneally, or orthotopically, meaning right into the pancreas, with 1 to 5 million pancreatic tumor cells. The microscopic features related to sites were different. In the subcutaneous group, the primary tumor was isolated to the injection site with well-defined borders. In the intraperitoneal group, multifocal tumor growth was noted on peritoneal surfaces. The majority was localized to the pancreas. When injected orthotopically or directly into the pancreas, there was ragged infiltration and patchy gross morphology. Hemorrhagic ascites was seen in the intraperitoneal orthotopic injected mice. Just like the Cosper and Line-1 study, sexual dimorphism was noted as males develop larger tumors than females, and this is further evidence of the cardiac protectiveness of estrogen. They showed that skeletal and cardiac muscle cachexia developed through different mechanisms, and this is again evidence towards autophagy being the driver of cancer-induced cardiac cachexia, at least in some cancer types or in pancreatic cancer. Skeletal muscle catabolism is driven by E3 ubiquitin ligase, MURF1, and adrigan. It's upregulated in cardiac muscles, but not as much as noted in skeletal muscles. The study supports Cosper and Line-1's findings. And there was also neutrophil-dominant leukocytosis. Miyagawa's study in 2020, again, used colon cancer cells and showed that the body weight in mice was reduced by 20% after day 9. Animals were moribund by day 14. There was mitochondrial impairment, autophagy acceleration, and myocardial immaturation noted. So again, further evidence of autophagy over the upregulation of UPS and cardiac cachexia that's induced by cancer. Atrophy was noted through a 62% reduction in heart rate and larger left ventricular dilation and 72% reduction of the cardiomyocyte area. MUFO and other studies showed that although tumor necrosis alpha and interleukin-6 were upregulated in mice in Lewis lung cancer, there were no differences in mitochondrial or nuclear volumes. There was a difference in the heart function between the lung cancer and control groups via echocardiogram. One of the most interesting study was the study of gene expression in cardiac and skeletal muscles during cancer-induced cardiac cachexia, or cancer-induced cachexia, not only in the cardiac muscles, but in skeletal muscles as well. They analyzed gene expression in cardiac and skeletal muscles in the C26, or the colon cancer mouse model of cancer cachexia. They found that there were 268 genes in the heart that were differently expressed, either up or down regulated, than in non-tumor bearing control group. However, in skeletal muscles, there were 1,533 genes that were either up or down regulated. But if you look at this Venn diagram, you will see that there were very few instances where both cardiac and skeletal muscle genes had commonalities. For example, look at C, skeletal upregulated, cardiac downregulated. There were only 6 genes that those two groups had in common. This, of course, according to Shum and others, led to different cellular changes as well. Similar to cachectic skeletal muscles, cachectic heart showed signs of inflammation, but did not show the upregulation of UPS system. And again, this is further evidence of autophagy being the primary driver in cancer-induced cardiac cachexia, and UPS being the primary driver in skeletal muscle cachexia. Sarcomeres are critical for cardiac muscle contraction relaxation. Thus, changes in sarcomeric proteins as the building blocks of cardiomyocytes can cause cardiomyopathy. Sarcomeric proteins are mostly upregulated and metabolic proteins downregulated across muscle types in cachectic conditions. What's interesting here is that during cachexia, there was disintegration of M line and Z discs within the sarcomeres. Basically, M lines and Z discs are the cytoskeletal structure, and so disintegration of this also depleted ATP in the mitochondria. Melanoproteinases break down proteins that can be found in extracellular spaces and play a role in wound healing, angiogenesis, and tumor cell metastasis. Melanoproteinases gene expressions were upregulated in the cancer or the C26 tumor-bearing mice, and collagenase MMP9 was upregulated at the protein level. MMP's remodeling of the extracellular matrix resulted in significant increase in the amount of collagen deposits in the heart muscle. In addition, the collagen byproduct hydroxyproline was found to be increased in the serum of the C26 tumor-bearing mice, suggesting increased collagen turnover. It is postulated that the remodeling and decreased wall thickness from upregulation of metalloproteinases may result in cardiac dysfunction and heart failure in the C26 tumor-bearing mouse with cachexia. So that's the animal studies. Pretty interesting. Most indicate that autophagy is the main driver. One study indicated or supported UPS as the main driver. And there is a possibility that both processes exist during cancer-induced cardiac cachexia, and it may have to do with the degree of cachexia or when the animals were actually sacrificed. More research obviously needs to be done. Human studies have not been able to specifically um, evaluate biomarkers as seen in animal studies because it wouldn't be ethically feasible to do a cardiac biopsy for the purposes of research in cancer patients. It's too invasive, and of course, there's undue risks. All biomarkers mentioned in animal research have never been verified in human subjects. We reviewed all the animal studies and human studies between 2011 and 2021 and noted for our criteria there were very, very few human studies. Most analyzed cardiac function and patient symptoms, and they were found to be very similar to those found in animal studies. But we can't really say that the same biomarkers specifically were present in human patients. Differences were noted between those with and without cachexia. Um, in one human study, age inversely correlated with stroke volume and heart failure in cancer patients, which indicated patients had a higher risk of cardiovascular events in these states, leading to cardiac muscle wasting. A similarity of the outcomes between animal and human studies related to GI cancers was that those with cancer had lower heart rates, decreased heart mass, and decreased heart function. These were indicators and contributors to cancer-induced cardiac cachexia development. Future studies are warranted to identify more clinically feasible biomarkers in humans and treatments that effectively and specifically block the upregulation of various genes and cytokines that facilitate cancer-induced cardiac cachexia using animal models. There is a demand for human studies on cancer-associated cardiac cachexia with more sensitive and feasible methodologies. Prevention of cardiac cachexia could ultimately result in better quality of life and possibly enhanced effects of therapeutics such as chemotherapy and immunotherapy, or give the patient time to receive those treatments and maybe even go into remission, hopefully. That would be the goal, right? Cardiac muscle wasting may be a result of cardiac proteins loss associated with increased oxygen consumption and energy expenditure. We talked about that earlier. And that, of course, leads to insufficiency and wasting. It's hypothesized that significant tissue inflammation and oxidative stress during cancer progression causes cardiac wasting associated cardiomyopathy. This study here compared hemodynamics in patients with advanced pancreatic or colorectal cancer or heart failure versus healthy individuals or control group. You can see here that in the advanced pancreatic colorectal cancer, there were 48 subjects. The healthy control group had 18 subjects, and the heart failure group had 37. The cancer group had an increased blood pressure, stroke volume, and cardiac output, lower body weight, but possibly because of increased metabolic demand, even leading to cancer-related cardiovascular issues. Cancer and control groups had a positive correlation between stroke volume and weight. Stroke volume decreased with age in the heart failure and cancer groups. Cardiac output correlated with age in the heart failure and cancer groups, and also correlated with weight in the control group. Non-cachectic cancer patients showed the least amount of cardiovascular symptoms in this study. Decreased melatonin production was measured in the urine, and it was more pronounced in the pre-cachectic and cachectic subjects. Cardiac dysfunction associated with cancer cachexia was evaluated through echocardiography and the assessment of left ventricular hypertrophy, pulmonary hypertension, and systolic and diastolic dysfunction of the left ventricle. Non-cachectic cancer patients showed the least number of cardiovascular symptoms. However, those with pre-cachexia and cachexia had the most cardiac findings, such as premature ventricular contractions, PVCs, hypertension, and either new or progressive chest pain secondary to coronary artery disease. Postmortem studies, we found one, and it was rather large. There were 177 deceased patients And pretty much the type of cancer was evenly distributed. Lung cancer had 58 deceased patients, pancreatic 60, and GI cancer 59. Cancer-associated cachexia equaled lower heart rate, weights. BMI, there was a correlation between heart rate and cancer patients. Heart rate, including left ventricular rate and right ventricular rate, were not significantly different between the cancer types, regardless of the cachectic status. So that means cardiac wasting appears to go beyond the type of cancer and may be more associated with metastasis. It may also, cancer-associated cachexia might also experience cardiac wasting through inter-tissue and inter-organ crosstalks. Treating cardiac cachexia early is important, if possible, before clinical changes are noted, and it may actually improve overall cardiac function. Our review showed that there was an increase in blood pressure, cardiac output and stroke volume, and maximal rise in left ventricular pressure in patients with pancreatic or colorectal cancers. Studies comparing stroke volume, cardiac output, heart rate, and blood pressure, along with echocardiographic findings in those with cancer-related cardiac cachexia versus individual with cardiac cachexia related to other disease processes, may be beneficial. Understanding what makes cancer-related cardiac cachexia unique from other causes may also lead to finding targeted, effective treatments. Now that the airplane has passed, we will continue. What we felt was needed is comparing biomarkers in patients with cardiac cachexia secondary to different diseases and compare those with cardiac cachexia secondary to cancer. Exploring biomarkers associated with cardiac cachexia from different types of cancer as well, versus the stage of cancer metastasis. Studies to determine effective targeted therapies and comparing hemodynamics in those with cardiac cachexia from various causes. These are the treatment trials that are being undergone currently. ACE inhibitors are felt to delay progression, and that's attributed to the improvement of endothelial function and the normalization of circulating IGF-1 and reductions in cardiac muscle markers such as ANP, BNP, interleukin-6, and tumor necrosis factor alpha. ARBs, beta blockers, and diuretics are also being tested. Interleukin A alpha antagonists, interleukin 1 beta inhibitors, interleukin 1 beta antagonists, and tumor necrosis factor alpha antagonists are also being studied. Currently, tumor necrosis alpha antagonists are shown to be ineffective. So these are things that are ongoing, and I'm sure other trials will come along in time. Thank you for listening. Please let me know if you have any questions. Please forgive the mistakes. I tried to go through this whole PowerPoint uninterrupted. Please forgive the screaming children in the neighborhood who are having fun, my dogs barking, jumping through the screen on the porch, cats hissing, and airplanes flying over our farm. Hopefully that wasn't too distracting. Thank you so much. Appreciate your time.